Yep.
Pretty good, actually, some of these. Okay, so this, anybody want to give this a crack?
So is this an excision? Or sort of a odd looking.
Yeah, whenever there's no epidermis, it probably means that they thought it was like a little cyst or something, and they kind of tried to scoop it out, sort of enucleate it.
And so then the contents here, they almost look collagenous to me, or like there's some collagen or.
Yeah, I mean, it looks like a neoplasm, probably.
It's a neoplasm.
And so it seems to be pretty small when you first look at it.
Mm-hmm.
So that would favor that it's probably benign.
And then the cells look a little, almost, stromal cells here.
Just keep trying him until you get him calm on the cell every 5 minutes.
Greg is fine. He's looking at
Okay,
He went
good.
upstairs.
He's not here. So they look kind of spindle, right?
Mm-hmm. Just spindly stromal cells here. And then they have kind of surrounding all the vessels. Really, there's no, didn't look, was well organized, felt like, for the most part. Thought it might be, see, there's vessels there.
So you've kind of got some little fascicles here. There's one. There's kind of another. There he is. There's another. And then another thing to look at is the stroma. So we're looking at spindle cell neoplasm. Look at the stroma and see if it's got any kind of fibromucinous characteristic to it, or plasma cells or something like that. That goes along with, in the skin at least, with neural neoplasia.
And so that's what I was kind of thinking. It might be like a large neurofibroma.
Yeah, it's not super large, but it's actually got multiple different little aggregations, fascicles of cells that kind of interweave.
Making it a plexiform.
Yeah, plexiform neurofibroma. And chances are it probably was large.
And they just took out a smaller.
Yeah, just a little small piece of it. They probably, and you know, what do you think they might have thought this was clinically?
Like a dermal mutant.
Well, the plexiform neurofibroma has got another characteristic. It sort of feels like a bag of worms, and so they often think these things are lipomas. You guys know how you biopsy lipomas. You take like an incision, you try to nucleate it out. So that's probably what they try to do here. But this didn't come out like a lipoma, because this has got it's like a basket weave. It's got tentacles that go way down into the fat, so you're not going to get something like this out. So anyway, that's a plexiform neurofibroma. Okay.
Slide it to the right.
All right. So we'll go to the next one. Do you have the PowerPoint to show also? So if we can take a look and see what it looks like.
I did. Okay.
All right, well, let's look at the next one in the meantime. All right, so what kind of biopsy did they do here?
Maybe the same thing. Wait, you can see the top of it. Maybe start off and punch and then manipulate it.
Could be, or they might have tried to do the same thing.
Yeah,
You know,
I
they
can
might
see
have tried
at
to
least
get
the
out.
middle part is the
It
same
looks like a
thing.
little ball, doesn't it? Like a little marble in the skin. So this might have felt, what do you think they might have thought about here, clinically?
So maybe a cyst.
Yeah, probably a cyst. So they probably took a little incision and maybe submitted the top part of the skin, and they said, well, hey, you know, there's something in here, and they just kind of try to pop it out. So is it a cyst?
It doesn't look like
No.
cyst.
Good. It doesn't look anything like a cyst. So it looks like a neoplasm again, right?
Another neoplasm. It looks, just from this distance, it looks similar to the previous one, just
A little bit,
gives
doesn't
the
it?
pink.
A little bit. But this one doesn't have like the fascicles of the cells that are kind of intertwining and interweaving. So it looks a little bit different. This one. Okay. There we go. It's better.
Are you on the first case or second?
Nope, we're on the second case. You can show them the first case, the clinical, just so you want to see what the first one looks like. That, see, show them that. Gross. Well, that's what the first, you can see the clinical up there looks like that. And then the next picture shows what they look when you do a, that's why they have all those fascicles, those little intertwining plexiform fascicles. And you can see that would feel like a bag of worms. It looks like worms. And those are pathognomonic of NFT. So if you have that, you have neurofibromatosis type 1 if you have one of those. So it's kind of important to diagnose it. Okay, so we'll go back to this one. So it looks a little bit like this, but it's not the same thing, is it?
So this, I mean, I see spindle cells like the previous
Yeah,
one.
you see spindle cells also. So it may be the same kind of differentiation, but it doesn't, it's in the plexiform neurofibroma this time, is it?
No, it looks less, maybe less cellular, more organized than the last one.
I would say organized. What do you mean by organized? I'm
The
not
other
sure I
ones, they
understand
kind of
what
like
that
crisscrossed,
means.
or it looks like the cells were kind of on top of each other. And this one, they kind of lay next to each other.
So you got spindle-shaped cells here, and they are in little fascicles, but there's not as many cells here, are there? It seems like there's more almost kind of like amorphous pink, maybe axons or Schwann cell cytoplasm in this one as opposed to the other one. There is some mucin in the stroma, just like the last one.
Okay.
So this is a similar lesion. It's also a lesion with neural differentiation. Notice the mast cells here. So anytime you have any kind of mucin in these lesions, and neural lesions commonly have mast cells associated with them.
So I thought this was a neurofibroma. I don't know if there's some sort of mucinous
There is.
differentiation.
There is. This one's just a regular, this one's a little bit different, like a little myxoid neurofibroma. So it's similar to the last one, but not quite as cellular, and it doesn't have all the fascicles that interweave. So this one's kind of got a round, well-circumscribed morphology. Almost looks a little bit like a neurolemoma also. In fact, it's theoretically possible it could be that, and that could be the pre-existing nerve. So when you think about the way that neurofibromas form, basically, if you think about a nerve and then somebody goes inside the nerve and maybe throws a grenade and the lesion develops kind of within the nerve and you get like the myxoid change, the cells and everything starts coming from inside the nerve. A neurolemoma, the changes occur from outside the nerve. It's almost like a knob occurring on a tree. So it's possible this could be like a myxoid neurolemoma as opposed to neurofibroma. Those kind of look similar, and actually, given that it's so well circumscribed, that's probably really what it is. But anyway, it's benign neoplasm with neural differentiation. You have two in a row, one that's a plexiform that's associated with neurofibromatosis, and then one that's just kind of a coincidental lesion that often looks like a cyst. So here's what these lesions look like. And clinically, they just feel like a bump in the skin.
And like a palisaded encapsulated neuroma would be more.
A little different ballgame. Then you get little
Embedded.
fascicles of cells that kind of interweave in that also, but the whole thing is small and round.
Small.
It's more cellular, less mucin, almost no mucin in those lesions too. Okay.
Okay, so this is a shaved biopsy, but there is no epidermis that you could see.
Yeah, there's a tiny bit. This, on a scale of 1 to 10, is like about a 2 on a good example, good biopsy. So these are crappy. We don't like this. So I guess it's good that we put this in because it's really what happens in the real world. This isn't the world's best example of this lesion because of the biopsy that was taken.
So from this tower, you see some blue, some pigment as well, some blue
Yeah.
cells.
So what you think it's, what kind of differentiation do you think it is?
I think it's probably melanocytic.
Yeah. Now do you think it's, can you tell whether it's benign or malignant?
This power, I mean, it looks a little disorganized from this power, so I'm not quite sure. Looking from
Tell
here.
me, again, you've got to educate me when you say disorganized. I'm not sure what
Oh.
that means.
Just not well circumscribed, because it's a shade. It's
I
not
mean,
really,
can you really assess the architectural
can't.
part? You cannot.
because it's not deep enough.
Yeah, you don't have breadth, you don't have symmetry, you don't have circumscription, so you really cannot assess the cardinal features of
Right.
benign or malignant using architecture. So you're going to have to rely on other things. So yeah, you're going to have to look at the individual cells and see if they're cytologic atypia, if they're mitotic figures. You're going to have to see if there may be some asymmetry based on just what you have here. So those are all things that you're going to try to use when you don't have the ability to apply those other things. So we'll look at it at higher magnification. Now when you say disorganized, what do you mean by that? How do you translate that into histologic terminology?
Haphazard.
That would be one, yeah. Fascicles of cells arranged in haphazard fashion in the dermis, splaying between them on collagen bundles. That's one manifestation of that. Maybe coalescence of aggregations or nests of cells. That could be another feature of it.
Uneven distribution of pigment.
Yeah, irregular distribution of melanin. Good. So those are some signs of asymmetry.
Right.
And that could be a sign of malignancy. So did you favor benign or malignant in this lesion?
I favored malignant, but I also thought of like a blue nevus.
Yeah, this is a
because
blue
I
nevus.
didn't find too much pleomorphism, and it was just hard to tell without the whole lesion. But I didn't see any like frank atypia or mitoses.
Good, excellent. If it's a blue nevus, if it doesn't have mitotic figures, it's almost always 99.9999% of the time benign. So it really needs to have cytologic atypia for it to be a blue nevus. And there are some cases of blue nevi that evolve into melanoma. It's rare. Some people call that malignant blue nevus, which is kind of a lousy term. So it's really not a malignant blue nevus. It's a blue nevus that underwent malignant degeneration, and usually it happens only in a portion of the lesion. So this is said to be atypical cellular blue nevus. To me, it's really not atypical at all. It is just a regular garden variety blue nevus. It's got some cellular areas and some dendritic areas.
How can you tell this is not a congenital nevus or a deep penetrating nevus without any other?
Okay, good. Deep penetrating nevi generally have a different architecture altogether. They're kind of dumbbell-shaped sort of thing going down in the dermis. So this really would not be the classic pattern of a deep penetrating nevus, which is a subset of blue nevus, by the way. And most all blue nevi are congenital. So they have cells that splay between them on collagen bundles and around adnexal structures. So blue nevi are a subset of congenital nevi in many ways. But this is a nice example of a blue nevus. But the problem here is that it's not a good biopsy. So that's the difficult thing. But this really was totally benign in this case. And I think you got a picture of that too, possibly. Okay, so these are just some blue nevi. Some blue nevi. The next one you can see has got one that does have more atypia. If you start seeing mitotic figures in blue nevi, we start getting concerned about them. But this is more kind of characteristic of the kinds of lesions that you get more concerned about when they get supercellular like that. Okay.
So this one was a shallow punch biopsy.
Yes.
I thought that there was some amount of acanthosis, which was pretty even, and then there was some hyperkeratosis too.
How old is this patient?
Old.
You think really old?
I don't know. Let me think again. Well, the fat. With young people, there's things like thinner. For the babies, you see fat sooner, but I don't see any fat there.
Well, notice that the punch is fairly thin, and it goes. This is probably the base. It's probably on the back or something. So it's pretty thin skin, and it has no sun damage. So it might not be a baby, but it's probably a young person, maybe a child.
Okay.
And that can help you with this diagnosis.
Yeah.
So your description so far is good.
Okay. So that kind of changes what diagnosis I had. So I thought there was some orthokeratosis, and I thought that there was some vessels, the superficial dermis forming, and then I thought there was some hemosiderin maybe surrounding the vessels.
There probably is a touch of that. Yeah, not a lot, but it might be a little bit.
So I was thinking because of the findings. I mean, I didn't see like a stratum lucidum.
What part of the body do you think you're on?
So because we have maybe acral, because unless it's secondary to the pathology, so maybe like the back or.
Yeah, good. It's probably like the trunk or the extremity, something like that. And you did notice that the cornified layer was quite thick, so what can you say about this?
There's no retention of nuclei, so it's just orthokeratosis.
Yeah, it's like hyperkeratosis. It looks like volar skin. There's a little parakeratosis over here, but this is marked hyperkeratosis with acanthosis, and it's not on volar skin, so by definition, it's a manifestation of.
Like scratching or something?
Yeah, rubbing, lichenification. So there's a sparse infiltrate. There may be a couple of melanophages there. It's a dark skinned patient, so this is melanin of the basal cell layer there. There's a sparse infiltrate of lymphocytes with an occasional eosinophils. Good. So what? And there's a tiny bit of spongiosis.
Mm-hmm.
So what's the possible diagnosis here?
So I suppose like lichen simplex or atopic dermatitis.
Yeah, good. Atopic dermatitis. And given that it happened in a young child,
Mm-hmm.
that would be favor that, since atopic derm is seen most commonly in younger individuals. So this is what atopic dermatitis looks like. Mostly lichen simplex, with a sparse infiltrate, maybe a little bit of spongiosis. So this is a beautiful example, except for that fold, of atopic dermatitis. So this is what it looks like when you biopsy it. And we get a lot of biopsies of this to differentiate this, say, from the drug reaction or from psoriasis, which you can see it really doesn't look that good for psoriasis. It's got irregular acanthosis, markedly thickened epidermal rhescia that have bridged. So those are all features of irregular epidermal hyperplasia. These are a couple of examples of kiddos with atopic dermatitis. And sometimes you can even get more spongiosis when it's in an acute, more inflammatory stage of it. So, and go to the next slide. That's the differential diagnosis of that. Okay. Did you guys actually get that?
I thought more in the prurigo category with all
Yeah.
these.
Well, basically, that's what atopic dermatitis is. It's the itch that rashes. So if you don't scratch atopic dermatitis, it goes away. You stick them in a coma, it disappears.
All right, so you have a shave biopsy here. And at this power, you can see nests of what I think are melanocytes,
Yeah.
mostly at the junction. Some are intraepidermal, but most are at the junction.
Can you assess the architectural criteria here?
As far as melanocytic,
Well, architecture, it seems to be small, well circumscribed, symmetrical, all those various things. I suppose
you
that
can
blue
see the
nevus
edge of
or
it.
something.
It's a little bit. It seems to be pretty well circumscribed. It's
Yeah, it
going
goes
too
to the
deep.
edges, but seems to be pretty well circumscribed right there. I agree with you. What about the symmetry?
looks pretty symmetrical.
Yeah, this fold looks like a Mad Magazine fold-out thing. You just fold one side on top of the other. It looks exactly very symmetrical. Mostly nested. Okay. Mostly at the junction. So what's the diagnosis?
I thought this was a Spitz.
Well, some of the cells are kind of slightly epithelioid.
That are just like a junctional nevus or mislet. I thought it had some congenital features though, but
Well, it's got some intradermal components, so it's not just
So
purely
just
a
to combine
junction
it.
nevus. So it's a compound nevus, but the nests are kind of large, aren't they? So it sort of looks a little bit like a Spitz, but it's not a classic Spitz's nevus.
just a compound with Spitz features.
You could if you wanted to, but the main thing is this is sort of what we call a nevus from a special location. This is from the axilla.
Yeah, okay. Special
And so there are certain parts of the body, when you biopsy nevi, they look a little different. Scalp, those often give you kind of larger nest of melanocytes with more, sometimes epithelioid cell features a little bit with more abundant melanin. The breast commonly gives you cells with abundant melanin. You may get a little slight pagetoid spread in breast nevi, so breast nevi can simulate melanoma sometimes. So If you get back to diagnosis of melanoma in a young individual in the breast and you really didn't think it was melanoma, you should get a second opinion. So it's not a good idea to carry a diagnosis of melanoma when you really don't have it either. Some people say, well, the worst thing is if you miss a diagnosis of melanoma, and that may be true, but it's not good to carry around a diagnosis of melanoma either. You get higher insurance premiums, people get paranoid, all sorts of stuff. So you don't want to have an overdiagnosis either. So it's just almost as bad in some cases to have an overdiagnosis of melanoma as an underdiagnosis. Nevi on the ear commonly look like Spitz's nevi, very common. Nevi in the groin area look a little unusual. Nevi in the acral sites, get pagetoid spread. So depending on what part of the body you're on, these lesions demonstrate some slightly unusual features. We don't need that. So these are just a couple of examples. This was one in the axilla. Okay, so just remember that certain special parts of the body will have unusual histologic features. So it's really more kind of like a map of your body. So if you biopsy a nevus just on the, say, the anterior abdomen, that may just look like a characteristic garden variety compound nevus that you read about in the textbook. When you look at these other locations, it can sometimes have some slightly unusual features. They can sometimes lead to misdiagnosis. Okay.
Very thin sheet biopsy. And there's some, you can see some pigment.
Yes.
In the dermatopathology junction. Yeah. And from this height, I cannot say much. Well, it looks like structurally organized, limited lesion.
Yeah, I mean, it seems to be very, I mean, the whole biopsy itself is what, about a couple of millimeters or less? I mean, a very small biopsy in low power. And then you get a little higher magnification. Yeah, you can see it's comprised of these melanocytes arranged mostly at the dermal-epidermal junction. And assuming this is the whole thing, it's obviously very small, seems to be pretty symmetrical, pretty well circumscribed.
The thing that was interesting with this one, at least in the computer, was the type of pigment that is seen all over the place, like in higher magnification. So basically, we were talking about, this is a melanocytic lesion. It looks benign or dysplastic. I mean, it doesn't go, but then this pigment, I've never seen this type of, I wasn't sure if it was artifact or what.
No, it's not artifact. It's real.
And I started looking, like, is this a fungus? No, it's like, but in the computer we couldn't see more. I mean, it was really a weird aspect of the melanin if it was just melanin.
Yeah, anybody know what these things are called? They're called melanin macroglobules. Anybody know where that has been described in the literature?
In this lesion?
Well, actually not very commonly in this lesion. This is really more of a evolved, like a genigo. It's like an evolving junctional nevus with some features of dysplastic a little bit. It's more kind of like a genigo, really, I would say. But it's been described in cafe au lait macules in people that have neurofibromatosis. So this has just got tons of these melanin macroglobules. It's really an interesting morphology. I mean, this is said to be a junctional dysplastic nevus, but it's not a classic junctional dysplastic nevus. It's definitely an unusual lesion that may be evolving, but this isn't the world's best example of a junctional dysplastic nevus. It's more almost kind of like a evolving junctional nevus with lentigo features with these melanin macroglobules. So that's probably the most important thing about this, is just to know what those are and know that's where they've been described. Dr. Fitzpatrick of Fitzpatrick's Dermatology textbook, he's the one that described that years ago. So it's a benign lesion. It didn't look like those, obviously. Those almost look like melanomas, so that's not a good example of junctional dysplastic nevus clinically. Okay. Next one.
Oh, thin shave biopsy here. Pretty thin. Long shape biopsy. And so going down, I think, can be kind of near in the epidermis here, I guess.
Yeah, so what kind of, what's the general overall
So
pattern?
pigmented, feel like a pigmented.
So melanocytic.
Correct, yeah,
Good.
melanocytic neoplastic lesion.
You think it's benign or malignant?
So I thought it was kind of on the border.
Good, good. If you thought it was on the border, that's probably good, because this isn't just a slam dunk obvious diagnosis either. We generally like to give you classic examples when we get teaching cases, but this one is not just a classic example because it's got conflicting criteria. It looks benign at low power. It looks fairly symmetrical. It looks relatively small. It's mostly nested. So overall, what's the overall pattern look like?
Like a nevus.
Like a dysplastic nevus. Yeah, so it looks like a dysplastic nevus. So when you start looking at it more closely, it's got a few areas where there are some single melanocytes focally above the dermathermal junction. But this isn't just a classic example. It's supposed to be melanoma in situ. And it's not just a perfect example of it.
That would be way too easy.
Yeah, well, it may not even be right. Because this looks a lot like a dysplastic nevus. I mean, it does have a few areas where there's a few single cells above the junction, but this is an example of a classic, obvious melanoma in situ. Now, what's over here? What are we looking at in this area?
So, like the normal.
Well, it looks like a solar litigo. Looks like solar lentigo. So it's not uncommon to get solar lentigo in one area, and then maybe melanoma in situ or dysplastic nevus in another area. So you have to be careful when you're biopsying these that you don't just hit the wrong area. So if you're worried about melanoma and it comes back as solar lentigo, go back and take another biopsy. You just want to make sure that you're not missing it. Don't just assume because the pathologist didn't call it a melanoma that it wasn't melanoma. This does have quite a few single cells in this area, but there's really minimal pagetoid spread. So this is probably one that may have come in as rule-out melanoma or something like that. Might have signed it out as possible evolving melanoma in situ in a dysplastic nevus. I mean, I don't know how this was signed out, but this isn't just a slam dunk classic melanoma in situ, so it's kind of a tough case. It's more of a real world kind of case, but not a perfect example of melanoma in situ. Okay, we know that pretty well. Okay, what'd you guys think it was?
Yeah,
I've hit melanoma in situ.
I couldn't decide.
Okay, good. Well, that's good. I mean, it's probably one that we would have recommended removal for sure. So I'm glad you guys thought that.
So we have a shaved biopsy.
Okay.
Something that looks kind of warty or verrucous.
Yeah. Yeah, it does look very verrucous, doesn't it?
It's pretty regular as far as like the acanthosis. And then obviously significant hyperkeratosis. There is a little bit of, from this view, just some sort of like cellular, maybe a little bit of infiltrate like around the epidermis.
Okay. What do you think the clinical was here?
It might have been something, so wart versus,
Yeah,
I don't know if it like
good.
SK or something.
Excellent. Good. So do you think it's benign? You think it's an inflammatory or neoplastic process?
From here it looks like it could just be, well, I don't think it's just inflammatory. I think
You think it's a
like
neoplasm?
Yeah.
Okay.
potentially neoplasm.
And you think it's benign or malignant?
From here it looks benign.
Good. Excellent. It looks fairly symmetrical, seemingly well circumscribed. We're not sure about that, but there's really not a lot of, it's got a flat bottom. It doesn't really have any irregularity to it that would be a sign of asymmetry if it had sort of deeper areas here and less deep here. And then I know you want to go to high power, everybody wants to go there as instantly as possible, but now that we get here, do you see any changes that look like that of a malignancy?
There might be some atypia in the epidermis because the cells don't all look the same.
Now, there might be some. On a scale of 1 to 10,
I said there are some abnormal looking.
There might be a
different
couple
looking
here and
cells.
there, but on a scale of 1 to 10 with regard to atypicality, what are you going to put this? 10 being the worst.
The lower end, like maybe 2.
Yeah, like maybe 1 or 0.1 maybe. So it's hardly any atypia. But there are a couple of mitotic figures here. And they're bipolar,
Mm-hmm.
and they're mostly at the basal cell area, but there might have been 1 or 2 above the area. What else do you see here? What about the cornified layer?
There's some parakeratosis.
Parakeratosis. What about the granular cell layer?
I don't see.
It's gone for the most part.
Mhm.
Good. What about the blood vessels?
Mm.
They're pretty dilated, aren't they?
Mhm.
Dilated and tortuous, and there's thin suprapapillary plates. So what if we took this by punch and submitted it as an inflammatory disease? What would you think about? You guys better get this diagnosis correct.
So this is psoriasis?
Psoriasis, good. Anytime I say that, you know the diagnosis has to be psoriasis. So yeah, this is psoriasis. Now why did they shave it and send it in as rule out squamous cell?
It was probably a small plaque, so like a guttate papule
Yeah,
or some
you can
sort.
get so-called verrucous psoriasis that can look like a keratosis.
Yeah, it does look more verrucous. than
Yeah,
I'm
it
used
looks
to seeing.
warty. And clinically, it can look kind of that way too. And the clinicians didn't have 1 or 2 small plaques. They think it's a cancer. They do shave on it, and it turns out just to be a localized area of psoriasis that can simulate a cancer. Now, what are a couple other inflammatory diseases that can look verrucous and whatnot submitted as cancers that are not, other than psoriasis?
Lichen.
Hypertrophic.
Trophic lichen planus. What else?
Hypertrophic.
Yeah, hypertrophic, yeah, discoid lupus. Excellent. That's commonly thought to be a keratosis. What else?
Seborrheic keratosis.
Yeah, seb cares. A lot of times you biopsy those and they have squamous cell carcinoma in situ developing, and we just wrote that up and published it just a couple months ago. There's 1 or 2 others. How about the infectious diseases where you get pseudoepitheliomatous hyperplasia overlying it? Right? So those are also, you want to make sure you don't misdiagnose those as cancers. So anyway, this was verrucous psoriasis. Okay, now, speaking of verrucous lesions, what's this diagnosis?
This one's a verruca.
Yeah, this is a wart. Now, why were you able to say wart here for sure?
I could see some coarse hypergranulosis, some poilocytes, really kind of compact, stratum corneum.
Yeah, this one's got coilocytic change, so that's pathognomonic. That's no different than seeing the multinucleated virulocytic pathic cells of herpes virus infection. Once you see something like that, you know that you're dealing with a wart. Now, any idea of which subtype of wart this might be?
I'm thinking condyloma, maybe, with this one. But
Well, condyloma usually has more of a gentle, dome-shaped, rolling hills kind of morphology. These are more digitated and
Just
papillated. So this would be,
filiform or something? I don't know.
well, filiforms are usually smaller, more vertically oriented with long papillae.
Just a good old Verruca vulgaris?
Yeah, just good old-fashioned Verruca vulgaris. And then, of course, you get Myrmecia warts, plantar verrucae, which are really marked, lots of viral cytopathic effect there. Marked verrucous epithelial hyperplasia, more acanthosis than we see here. What about the lesions that occur in the mouth that look kind of like, a little bit like lichen planus, whitish plaques in the mucous membrane that are caused by HPV? What's that disease known as?
Oral papillomatosis.
Well, that looks like verrucous carcinoma.
Okay.
What about they look kind of like little white lichen planus-like plaques, small papules on mucous membrane?
Like leukoplakia? Like
Well, that's a squamous cell carcinoma in situ.
Squamous.
No, that's in the carcinoma category. There's a specific HPV type that's associated with that.
sponge nevus?
No, that's not even a HPV-induced lesion.
No. I'm not sure what
You guys don't know? Hex disease?
Hey, no,
HPV
I
13?
was thinking of like
Okay, so remember that one. The board likes to ask that one every now and then. So these are just some examples. The one on the eyelid is a filiform wart. See how that thing is kind of more vertically oriented? So these are just garden variety Verruca vulgaris in this picture. Okay, so that's a Thanksgiving gift there.
Yay.
Okay. This one, we actually have a better one of these we just saw yesterday. This isn't a real good example of this entity.
Yeah. Okay. So for
And this is impossible to diagnose, by the way.
it's impossible. Oh goodness.
Godspeed.
Good.
I just described it.
Okay.
I was like,
This side
Yeah, me
actually
too.
is, maybe is diagnostic on this side a little bit.
Okay.
This side, no.
So I thought it was quite fun. There was some acanthosis for
Yep.
sure. The surface was a little papillomatous, which maybe threw me off a little bit. And then there was some overlying hyperkeratosis in the other cot, which was pretty compact. In terms of like the dermis, there was some. I thought there was some superficial, maybe sparse infiltrate, but nothing too interesting going on that I could identify. I put it in like the psoriasiform category. I'm not sure if that's right or not, and then tried to look for features to define it further. I didn't think it felt with it fitted with just plaque psoriasis.
Now, see, you'd have to have some history on something like
Okay.
this. But yeah, you're right. It looks psoriasiform. This is sort of cut tangentially. But it's not really classic psoriasis, is it?
Mm-mm. So I mean, there wasn't any like it didn't look like syphilis. There wasn't any plasma cells. I didn't think there was like narrow-rete. I thought about PRP, but because it was sort of maybe checkerboard, but not really.
Yeah, not really. It doesn't have really any orthokeratosis at all, does it?
No. Yeah. So I kind of went through that psoriasiform differential, but I didn't really feel like it fitted perfectly with anything. So that's kind of what I came up with.
What if I told you it was
Yeah.
linear?
Oh, like Ilvin?
Yeah, this isn't a perfect Ilvin.
Mm-hmm.
This side, what does this side look like?
There's no orthokeratosis.
Right, nothing. This looks like this papillomatosis,
Yeah.
basically. So this looks like just a garden variety epidermal nevus.
Mm-hmm.
Like a psoriasiform epidermal nevus possibly over here. Usually Ilvin, the cornified layer on this side does look like that you can see with an Ilvin. So this is reasonable over here. And I think the clinical photomics that we sent for my presentation didn't have this side. It had only the other side, which doesn't really look like Ilvin. This side looks closer to Ilvin, but usually you'll get this kind of parakeratosis, usually like this. But it's sort of in stops and starts. You'll have an area, and then you'll have a zone where it's normal. And you have another area where it's abnormal, and an area where it's normal. So here it's kind of confluent, which is a little bit unusual. But this side is consistent with an Ilvin over here. This side is not. This is not what Ilvin looks like. This is what kind of just a garden variety psoriasiform papillomatous epidermal nevus would look like. And sometimes they're really papillomatous, look like multiple skin tags. So this would look like maybe just a linear epidermal nevus, not otherwise specified, with maybe some psoriasiform hyperplasia. But this side would be consistent with a slightly unusual variant of an Ilvin. So notice the parakeratosis. It's not really inflammatory parakeratosis. This is a disorder of cornification where the nuclei are just kind of retained. And you see that in a number of these congenital keratodermal-like processes, like Conradi-Huneman disease. You'll get like retained nuclei in the cornified layer in columns within small cysts in the epithelium. So this is Ilvin over here. Here's a little bit of vascularly cornified layer, but it's kind of interesting because it's kind of a little bit more diffuse and broad. But you wouldn't really know that. I think if you saw this kind of keratosis in the future, you might say, well, this doesn't look like typical parakeratosis. There's no mounds, no inflammation, really, no spongiosis. So maybe it's not just a classic parakeratosis from an inflammatory disease. It might be a true disorder of cornification, maybe something like an Ilvin. And you'd have to know that it was linear. You couldn't just pick that up. These are a couple of examples of epidermal nevi. So there are other patterns that we see in epidermal nevi. What else can you see besides, I call it a psoriasiform linear epidermal nevus. What else can you see when you biopsy epidermal nevi? histologically?
EHK.
Yes, EHK.
Oh,
What else can you see?
Other histologic changes when you biopsy epidermal nevus. So you know two of them. You know the ovin now. You know the one that can look like psoriasis. You know I told three actually. Told you one that looks kind of like multiple skin tags. What if you see focal acanthlytic disc keratosis? What's that called? Linear Darius, right?
Mm-hmm.
And that's a linear epidermal nevus also. It's a somatic mutation.
Mm-hmm.
Okay, nevus sebaceous, that's a type of epidermal nevus in a way. It's kind of epidermal connective tissue nevus. Nevus comedonicus, nevoid porokeratosis. So there are a bunch of different histologic reaction patterns you can see in a linear fashion when you biopsy them. Sometimes you don't know what you're going to see. It's kind of like a box of chocolates, like Forrest Gump said. You sort of have to biopsy it to see what's going to be there. Okay, who wants to give this one a go?
Alright, so we have, I guess it's maybe a large shave or excision of this.
Yeah, exactly.
It's like a papule or,
Pretty big papule,
Yeah,
isn't it?
very
Like a
large.
nodular tumor. Fills up the whole screen at 1x.
Have these kind of frond-like projections, this kind of papillomatous architecture.
Yeah, good.
So whenever I see this architecture, I always look for the like foamy cells to make sure this isn't a Verruciform xanthoma.
Okay,
kind of
that's
like
good.
In the, I guess in the tips, which I did not think I saw.
Good.
This
You
one.
did not. Excellent.
So I was going more of just like condyloma, and this one just kind of a regular
Okay.
HPV type.
It goes fairly deep. So yeah, it could be condyloma, but it's getting pretty deep, isn't it? So what do you think about in that situation? Yeah, and he's asking a question sort of in stops and starts there too, but
Yeah.
how do you tell what from what?
No, how do you tell it's getting that deep? Because I was like, looks more exophytic.
It is pretty exophytic.
Shaved it off.
You're right, it is. Although, you know, it's kind of getting down to the reticular dermis. So this. It does look like HPV-induced lesion, and we could call it a giant condyloma. So it's kind of the border is between this and whether it's really Verrucous carcinoma, because the Verrucous carcinoma is really made on the basis of architecture. It's not really made on the basis of cytology. So if you biopsy, if you do a shave of this, you see call it condyloma all the time. It gets really deep, and sometimes you can say, well, this is probably giant condyloma, or it's bordering on true Verrucous carcinoma. Still looks pretty benign. I think you wouldn't want to just leave this in place. But we've seen some giant condyloma that really weren't cancers that can look like this. So that's a good question that you ask. Usually, if it's really going to be giant, like Verrucous carcinoma, you probably want to see some of this area involved.
Yeah. Right.
Going all the way down into the deeper structures. But this was an attempt to show an example of a Verrucous carcinoma. This is kind of what they look like, only they often will go deeper. You look carefully at these, you might see an occasional mitotic figure, but they're generally not very atypical. So it's kind of like DFSP. That diagnosis is malignant because it goes so deep. This is malignant also because of depth of involvement as opposed to atypia. Now, it does have a couple of mitoses. And sometimes these lesions do actually become, frankly, cytologically atypical as well, but they don't have to. They just gradually cause problems because they keep getting deeper and deeper and deeper and get into bone and muscle and blood vessels and all sorts of negative things. So these are some examples. Now there are several histologic subtypes of this too.
Yeah.
So what do you call the one that's in the HPV induced in the groin?
That's
No.
the
Bushki-Lowenstein.
Bushki-Lowenstein, yes. What do you call the one that's in the mouth?
No, or Florid papillomatum.
Yeah, what do you call the one that's seen on the foot?
Cuniculum.
Yeah, carcinoma cuniculata. Excellent. Okay, so those are just a couple of examples of those. Okay, got another interesting case here.
All right, so this looks like a shave
Good.
of like a papillomatous or verrucous papule. I'm not sure what they were thinking they were going to find there.
Yeah,
But
probably wart or
Yeah.
something like that. Yeah, absolutely.
But basically, what I saw here, I cannot really identify what exactly source is, but I told Greg, I remember I saw it, and I was like, this is adenocarcinoma.
Okay, good. So you thought it was malignant? You thought it was
Yeah,
glandular? You thought
Yeah,
it was...
it's exactly. There are like these tubular, glandular structures resembling, like almost like reminded me of some parts of the intestine. Like
Yeah, GI tract.
Yeah.
Excellent. Now, how do you... Usually do you get adenocarcinoma with all this Verrucous epithelial hyperplasia?
I'm not sure about that.
It's pretty unusual, isn't it?
I mean, unless it's contiguous and it's like a reaction to it, or
Yeah, it could be probably contiguous. Any idea what part of the body?
I guess either close to the ends, mouth, or
Yeah, near a mucous membrane.
Exactly.
And if it looks like intestine, where is it most likely going to be?
most likely probably perianal.
Yeah,
area.
perianal. Well, then this Verrucous epithelial hyperplasia could be related to background HPV infection. But notice this area right here. These cells are actually colonizing the stratified squamous epithelium. They're actually growing into it.
Yeah.
So this is an example of a contiguous lower GI carcinoma that's just growing into the Verrucous epithelium of the perianal area. So it's an interesting lesion. So it is a colonic adenocarcinoma. So it's not really a MET in the same sense. It kind of is, but it's almost like it's just kind of like growing into it in a contiguous fashion. So it's not. This is probably not really spreading through blood vessels and lymphatics. It's probably just kind of like the old crab cancer direct spread. Now, what else does this besides this pattern in this location?
What else does this, as in?
It involves the epithelium like this. It's a variant of an adenocarcinoma.
No.
Breast.
What'd you say? Somebody said something that's probably correct. You just have to say
I
say
said
it loud
Crohn's,
enough to get
but-
credit for it.
I said breast.
Well, breast wouldn't occur in this same location,
I
right?
thought you said different location.
No, in this location. But you could say the breast. There is something analogous to this in the breast.
I mean, Crohn's
Yeah, we
could
saw
do
that
it, but it
with
wouldn't be
Crohn's.
as
Yeah, but
typical.
Crohn's isn't a cancer.
It's not a cancer.
So what other contiguous carcinoma involves the perianal GU epithelium, but it doesn't give you glands most of the time? It can, not this many, but it's mostly in the epithelium. Extramammary Paget's, right? Extramammary Paget's is always associated with an underlying carcinoma of some type, either GI or GU or prostate. So if you get extramammary Paget's, you got to look to see if they got something internal. They don't have to, but they often do. Just like mammary Paget's always has a breast cancer with it. You just have to find it. So this is sort of analogous to that, only instead of being single cells, it's glands here. It's the same idea. So I think we have a picture. See, look at that picture. See, look, it's kind of warty. So again, that may have been an HPV-induced lesion in this case. I don't know for sure, but that's just where the cancer kind of grew into the area. So it's an interesting situation. Okay.
So I'm looking at a punch biopsy here.
Yes.
Chronicle skin. Kind of a pretty deep punch biopsy.
Yeah, there's actually, notice there's two elements of it. There's a crunch that goes into the fat, and then they actually did a vertical and a horizontal section. So this is, they took part of it and did it vertically and took another part of it and cut it this way, horizontally, so you could assess the number of hair follicles. So this is from the scalp, I'll just tell you that. So normal scalp or abnormal scalp? Very abnormal. What should we be seeing here?
So you see more hair follicles?
Yeah, a lot more. We see none here. You know, maybe one burned out one over here, and then we've got nothing in the fat. We should normally see about 8 to 10 deeply seated anagen follicles sitting in the fat. So this is a alopecia. Now, do you think it's an inflammatory or non-inflammatory alopecia? Kind of hard to say on this side because that's kind of dead. But we look over here.
And so it looks inflammatory.
Yeah, inflammatory. Good. And is it going to be permanent or non-permanent?
So I thought it was a little hard to tell because I know.
Nah, it's easy to tell. Easy. What's this stuff?
That's the collagen.
Yeah, is that normal?
No.
No. What's going on there?
So it's scarring.
Scarring. It's choking off the follicle. Is that going to ever regrow? So it's permanent. So permanent, inflammatory, scar, this ain't coming back. It's going to end up like this. This is a wasteland.
Yeah.
Okay, so what permanent?
Lichen planopilaris.
Yeah, lichen planopilaris. When it's at this stage, it's hard to tell if you see only that because CCCA can kind of look like this. But if you have this, you're home free. A lichenoid infiltrate around that follicle right there. That's classic for lichen planopilaris. And then it ends up like this. And if we had a decent biopsy from the vertical, we'd see fibroplasia around the follicle. Now, there's maybe a touch of it here, but it's very, very difficult to see. Almost impossible to see. Here's the residuum of a hair shaft that's been destroyed. So this hair shaft, the scarring alopecia happened, the hair shaft got free, got secondary granulomatous inflammation. This hair is just sort of there as a foreign body reaction. That's due to the destruction of the follicle. So this is lichen planopilaris. Normally, you get inflammation occurring in this area there. You really see that nicely. So if you see that, that's really helpful. That's what we look for. That's where you can see that, boom, you got an instant diagnosis. This is helpful over here too, when you get that, but that's great if you see that.
I was a little bit confused with the depth of the second part, where exactly, because it's in almost in the fat, and I was.
Well, this is really cut kind of in the lower. Yeah, you're right. This tends to be. This is slightly, but usually that's where it can extend a little further down. I think this is probably just near the bottom of that area, just a little deeper in this field.
Because
you're right. It's better to see it right at that area.
Yeah. Okay.
Yep.
Good.
Okay.
So we have the shape biopsy. It's pretty long shape biopsy. And this was a melanocytic lesion with
Melanocytic?
I think so, and then a dense
Now, you thought it was melanocytic because it had melanin, right?
correct.
And what if I told you this person had dark skin?
Okay. And I saw that there was a dense infiltrate.
Yeah. And what's the pattern of the infiltrate?
That's supposed to be nodular.
Well, it's kind of lichenoid, isn't it?
Lichenoid, yeah,
Yeah,
it's
it's
all
focally
along.
lichenoid. And what kind of cells are these?
I see lymphocytes, quite a few.
These are lymphocytes.
And then
What about
they're
these in the center?
melanocytes.
Are those lymphocytes? They have more abundant cytoplasm, don't they?
Mm-hmm. So they histiocytes?
Yes, histiocytes. And they predominate in that little focus there. So you've got a small nodular aggregation of histiocytes with a lichenoid granulomatous pattern. And you've got one little papule here, and then you've got another little papule over here. And another little papule over here. Any idea of what the diagnosis might be now?
It looks malignant to me because, well, I see the lymphocytes kind of traveling up. I don't know if the lymphocytes, there's like pagetoid or epidermal tropism.
There's a tiny bit of that, but you don't have any protease collections, and the cells are small and typical, and So what
Yeah, I
were
think
what did you
so.
think it was then?
So, because at first I thought it was a melanoma, but since you're saying there's not any melanocytes,
Yeah, that's mostly just epidermal hyperpigmentation in a
okay,
dark-skinned person. And this was a child.
a child. I think of
So if I told you it's lichenoid granulomatous with little small papules, 3 of them in one shade. Does that ring any bells?
no.
It's like a ball and a
Ball and
claw.
claw.
Yeah,
Oh,
it is ball and
lichen
claw
nitidus.
here. Yeah, this is lichen nitidus. Lichen nitidus, okay. I think we have a picture of that
I
too.
saw that and I was like, there's no way there would be 3 in one.
There can be,
Absolutely.
yeah, look at that. Look how many there are on the back of that kid's hand.
It's
You
just
can
a
easily
beautiful
get 3 of those. These are often seen, they often are seen in dark-skinned patients. Doesn't have to be, but they're also seen in the genital areas, a common location, penile area. So lichenoid granulomatous, there's not too many diseases that can give you that pattern either, so make sure you know that. All right, one last one.
All right, here we have a punch biopsy. There's sort of this mild superficial vascular infiltrate. That
Yeah.
just looks pretty normal.
Good.
Um,
Any abnormality in the cornified layer?
there's some mounds of perikeratosis.
Good.
There's maybe a little bit of spongiosis as well.
Yeah.
Vulgaris of spongiosis in the epidermis.
Definitely spongiosis. Anything else?
A little extravasated blurred blood cells.
Yeah. So
Pityriasis.
put everything together.
Pityriasis rosea.
Yeah, this is classic, beautiful example of Pityriasis rosea. So this is a teaching example for PR. It doesn't get any better than this. This is classic. Superficial perivascular dermatitis, spongiosis, kind of slight spongiosis with extravasated erythrocytes, mounds of perikeratosis with really no neutrophils in the perikeratosis, usually a couple lymphocytes. So this is fantastic for PR. Can anything simulate PR? Histologically? And clinically for that matter.
Syphilis.
Yeah, syphilis can simulate it probably more clinically than histologically, but yeah, it can.
Some of the gyrate erythemas.
Yeah, superficial gyrate erythema can. And if you biopsy the herald patch of PR, it looks like a deep gyrate erythema. The
It can have a little interface too. Right?
the purpuric, persistent pigmented dermatitis associated like the Verrucous and Capitanochus, the widespread form can look like PR. You get some viral exanthems, like a purpuric viral exanthem, and we now know the PR we think is caused by HHV, what is it, 7 now they're saying, or 6? So this is, it is a purpuric viral exanthem. And then a purpuric drug reactions can look like this. So there's several things that can look like this. There actually are PR-like drug reactions, Gold and a few others that can do it. So there's the clinical of it. So this was a great example of PR. Okay. Have a great Thanksgiving.
Thank you.
Thank you, Dr. Cockerell. Happy Thanksgiving.
See you guys.